Good day and welcome to our oral health seminar series. We'd like to welcome Lisa Robinson and Stephen Resch of the Harvard T.H. Chan School of Public Health. A little bit of background about both of them. Lisa is a senior research scientist at the School of Public Health, where she is the deputy director of the Center for Health Decision Science and also affiliated with the Harvard Center for Risk Analysis. She has led numerous assessments of the costs, benefits, and other impacts of environmental, health, and safety policies and regulations, developed related methods, and drafted guidance documents. She is a past president of the Society for Benefit Cost Analysis and on the editorial board of the Journal of Benefit Cost Analysis. Welcome, Lisa. And Stephen Resch is a lecturer at the Department of Health Policy and Management at the Harvard School of Public Health. Trained as a health decision scientist, his primary research interests are health resource allocation, operational efficiency of healthcare service delivery, and the adaptation of decision analytic methods to global public health challenges. He has developed costing tools and computer-based simulation models to support resource allocation decisions and economic evaluation of interventions in several areas of public health, including HIV, tuberculosis, maternal mortality, malnutrition, surgery, dental care, and immunization. We're thrilled to have both of them speak today. They will be going through some presentations and stopping during the presentation to take questions. If you have a question, please submit via the Q&A function or rather the chat function on your Zoom. Thanks so much. Lisa and Stephen, take it away.
Thank you very much, Christina. This is terrific, and we will stop at major places in the presentation. Oh, geez. This is sorry. My slides aren't moving. It's there we go. Yay. So this is a little bit dangerous to do when you only have an hour, but we're going to try and do at least two things. We'll see how successful we are. My understanding is that the people who are listening to this are have varied backgrounds, and many of you don't have that much familiarity with these economic evaluation tools, cost effectiveness analysis and benefit cost analysis. So what I'm going to do is give sort of the 30,000-foot view of these methods and provide some additional resources that you all could look at if you want more. I'll pause for questions, then I'm going to turn it over to Steve, who's going to tell you about this cool project that we're working on pediatric preventative care. And then if we have time at the very end, I'll talk about what's the last dash here, the validating dental health improvements, about some work on estimating people's willingness to pay for dental health improvements. So, excuse me. I like this toolbox graphic because I think of myself as, my background's in policy analysis. I think of myself as sort of walking, every time somebody says, I need you to do an economic evaluation of something, I think of myself as sort of walking into a hardware store, and I need to figure out what toolbox is the right one for the problem that I'm trying to address. Once I've picked the toolbox, then that has implications for what tools I put in the box. Some of these forms of economic evaluation use some of the same tools and some different tools, but understanding which world you're trying to work within is really important. Oh man, I'm sorry, I'm having, my computer's not liking me today. I've only done 5 million Zoom things, and there we go. If we're in the cost effectiveness toolbox, what we're going to do is estimate the cost of the intervention by a non-monetary measure of benefits. And then we're going to summarize the results as a ratio, a cost effectiveness ratio. In these sorts of analyses, we often use outcome measures that integrate changes in health and longevity, but are not monetary measures, QALYs and DALYs. Steve's going to talk a little bit about why these measures are sort of problematic for dental health. Cost effectiveness analysis is typically used to prioritize medical intervention. A lot of times you'll see it called HTA, health technology assessment. So the types of questions that it is really good at answering are things like, what's the best approach for treating a specific condition, or what intervention should be included in a health insurance package or universal health coverage. Benefit cost analysis has a lot of the same tools, but also a few different ones. What we do is we sum negative and positive impacts, usually referred to as cost and benefits, measuring them both in monetary units. The results are summarized as an estimate of net benefits, benefits minus costs. You'll see in a lot of these analyses, especially in public health, that people like to report cost-benefit ratios or estimates of return on investment. These ratios are problematic, though, because what people include as costs and what people include as benefits differ across analyses. So we need to be really careful that we're not comparing apples and oranges when we're looking at these ratios. The way we come to monetary measures of benefits is by estimating individual willingness to pay for changes in health and longevity. If we have time, I'll talk a little bit about how we're doing that in the dental health context. The idea is that what we want to know is the extent to which people are willing to exchange their own income for improvements in their own health. Benefit cost analysis is really widely used, but mostly outside of the health system, healthcare sector. We use it commonly to assess regulations, air pollution, traffic, and food safety, and for public health policies like smoking, where the intervention might be undertaken outside of the healthcare system. I'm going to turn now to a 10,000 foot, 30,000 foot view of the tools. This flowchart is something you'll see in a lot of the things that we've written, and I've got some references later in here. It shows the components. Well, it was originally designed to show the components of a benefit cost analysis, but it works well, I think, for cost effectiveness analysis too, because the general framework is really the same. I've illustrated as a sequence just for simplicity. In reality, what happens is you go through these steps, you learn something new, you go back and refine what you've done earlier. I'm hoping that the first two boxes are pretty obvious. You need to think about what problem you're trying to resolve. You need to think about what the options are for solving that problem. In this exhibit, we use policy as sort of a generic term to refer to interventions, which may be medical, they might be regulatory, anything that we do in order to address the problem. This term standing comes from legalese. It's this idea of whose costs and benefits count. The word standing is often used in benefit cost analysis, and cost effectiveness analysis, we often use the term perspective instead. Both types of analysis could be done from either a healthcare system only perspective or from a total societal perspective. In CEA, the current recommendations, I think, are to show the results both ways. In benefit cost analysis, we usually look at the total societal perspective. If it's a healthcare system perspective, then the focus is on expenditures within the healthcare system and benefits to patients. If it's all of society, you might look at spillover effects. You might look at effects other than health, a number of different things. So when I talk to people about benefit cost analysis, they often think of the monetary estimates as the most difficult part, but it's not the case. The most difficult part is something that everybody on this webinar probably does it to some extent, which is to think about the difference between two sets of responses. And what we often do is we say, here is what the world will look like without the policy. And that's the baseline. And we compare it to what will happen with the policy or intervention. The one challenge here is that that baseline comparator, it's predictive because anything that you're assessing today isn't going to be implemented today. So we really need to think about whether there's things going on in the world that will change what's happening, even if we don't implement the baseline. I mean, even if we don't implement the policy. The biggest problem with many of the analyses that I read is that the comparison is not clear. It's not clear what the analysts are thinking will happen without the policy, and understanding that's very important. In cost effectiveness analysis and benefit cost analysis, we use the same approaches for estimating costs. We focus on opportunity costs. The idea there is that The value of a resource is using it in the way that most enhances welfare. And that if we use resources like labor and materials for one purpose, they won't be available for other purposes. I just realized it as I put this picture up that maybe this isn't the greatest for a dental health audience, since I think these people are buying juice or something sweet like that. But the the idea is if they buy the juice that's in the guy's hand, they can't use that same money to buy whatever it is that the woman's reaching for. So there's a trade-off. There's an opportunity cost of that spending. Benefits is where there's the biggest difference between CEA and BCA, where we use non-monetary measures in CEA and monetary measures in BCA. And finally, both BCA and CEA as conventionally conducted just aggregate everything. And every single best practice set of recommendations I've ever seen says that's not enough. You also need to think about the distribution. How does the intervention affect the wealthy versus the poor? And despite this recommendation that's made over and over again, a lot of analyses don't do that. So it's worth, I think, emphasizing how important that is. What's here are a couple things for further reading. We, on the Center for Health Decision Science website, there's a repository link, and under there are lots and lots of other things that you can read, but these are some very basic things. The first thing is what's often referred to as a second panel book. They also have a JAMA article where I think Gillian Sanders instead of Peter Newman's the lead author. Those are the current recommendations for best practices in the US. The second reference is a Gates Foundation funded project that provides similar recommendations for global health. For benefit cost analysis, I included the guidelines for the US Department of Health and Human Services, since they encompass all of the health agencies, including CDC, the Center for Medicare Medicaid Services, so NIH, all of the organizations that most concern us. So their guidance is probably of key importance. The second is for those of you who are more interested in global health. These are some best practice guidelines that we wrote, again, for the Gates Foundation. Are there questions? I don't see anything in the chat. Christina, do you have any? Does anybody have any questions? Do you want to raise your hands? What's the best way to do this?
Nothing has come up yet, so I think we can proceed.
Okay. Let's see. So Steve, I think I just stopped my share and you'll pick it up. Is that?
Yep.
Okay, here we go.
Hi, everyone. So I'm going to talk a little bit about an example where we're trying to use this toolbox of economic evaluation applied to dentistry. And it really comes out of two grants that we've been a part of that are led by folks at UCSF. The project is focused on preventive dentistry for children and focused on reducing caries. And I haven't listed all the objectives of the research, but just focusing on the one that relates to today's topic. Really what we're trying to do is to determine if Medicaid patients receiving a standardized risk-based caries prevention program have improved and cost-effective long-term oral health outcomes, where the principal measure is a reduction in new caries. Compared to Medicaid members that are enrolled in standard other dental plans. So really this is a question of, does the intervention or the approach, does it work? What's the health impact? And here we're primarily measuring that in fewer new incidents of new caries. And then the question is it worth it? What's the economic value? So the setting here is in the state of Oregon, and the intervention is taking place, or it's actually the standard of care at this large dental group practice called Willamette Dental Group. And it's a large risk-bearing dental group practice, meaning it's capitated, so they get a fixed amount of money per member per month. And so they have certain incentives to be cost efficient that fee-for-service dentists may not. It's a large group, 53 offices in 3 different states. Most of that is in Oregon, 1,200 employees, 400,000 patient visits a year. And because they're capitated, they've invested a lot in prevention. And they have this risk-based caries prevention plan, which is quite similar to a published approach to risk assessment called CAMBRA, which I guess as dentists you'll probably be more familiar with than I am. In this particular study, we're focusing on pediatric patients, although they use this approach for their adults as well, and there are other studies ongoing in the adult population. The study originally was supposed to have 7 years of longitudinal data, which it will, but of course we had COVID this year, which has been a major disruption in normal care, the evolution of normal care. So we're not really sure yet what to do with that, but nevertheless, we at least have a 4-year time horizon before COVID hit of longitudinal data. Now, we have information within Willamette Dental Group. We have information on both their commercial pay or their accountable care patients, which is basically the commercial plans, as well as their Medicaid patients, which in Oregon is called the Oregon Health Plan. In addition, we have claims data for all of the Oregon Health Plan, not just Willamette, but all the other Medicaid providers of dental care, which at a high level, all of those providers are paid by capitation. However, at the provider level, some of those groups or CCOs might be paying their providers still fee-for-service, which is not the case at Willamette, if you're interested in that sort of thing. And in our study, we're comparing both within Willamette, the commercial pay to the Medicaid patients to look at some specific aims related to reducing disparities, socioeconomic disparities in dental health outcomes. But what I'm going to talk about today is focused on a comparison within the Medicaid population of those who are getting the care model from Willamette versus other dental providers. And basically the way the program, the intervention works is that, when the patients come in, at their initial visit, they're going to get a caries risk assessment, which is going to look at a number of factors and then classify them as low, moderate, high, or extreme caries risk. And then they're going to get a dental care plan that's based on their risk level, which is outlined here. The thing to note is that basically if you're a very low risk, then you're getting probably even less in terms of services that as you would get in a sort of normal fee-for-service dental practice where you come every 6 months for your checkup. If you're in a moderate level, you're going, it's pretty standard. And then they really invest a lot more in focusing on the high and extreme group with more frequent follow-ups and more intense treatment plan involving prescription toothpaste and chlorhexidine rinse, silver diamine fluoride, all these kinds of things that, again, you all will understand better than I will. But the point is that they're spending money on trying to, they're investing, if you will, in those patients to get whatever decay they already have under control, as well as to put them on a plan that works toward lowering their risk. And, you know, of course, over time, patients can adhere to that plan or not adhere to it. Over time, their risk level can adjust based on how well it's working. The measures of decay missing filled surfaces, or DMFT or S, can change over time. The number of new caries changes over time. And then this last one, POQUL, is actually a measure of oral health related quality of life. It's a survey instrument given to children or to the proxy parent if the children is very young, which is something we're measuring, but just in a sample of patients. And all of these outcome measures that I've listed here are observable within Willamette's system because they have a Axiom electronic dental record system to look at all of this. But for our Medicaid comparison, all we have is claims data. So in comparing Willamette to other dental practices, the main thing that we can see is new caries. But again, we only really see them if there's a claim related to it, basically, you know, a claim for a filling or something like that. But we have this longitudinal data, and if you just focus on the top there, in this claims data, if you look over time, we have the Willamette Medicaid patients and the other Medicaid patients, and they can have, the green circles are supposed to be preventive visits. The orange are basically treatment of prevalent decay or decay that existed when the patient became a patient in that practice. That gets treated sort of up front. And then the red diamonds are what you're trying to avoid, which is new decay. And this slide is really just illustrating that because of the dental record, for the Willamette patients, we actually have a lot more detail in terms of whether they've been adherent and whether their risk level is changing and so forth. But in the claims data for the Medicaid patients, for those that are not at Willamette, we don't know their risk level. We don't know their adherence, and frankly, we don't even have like a measure like DMFS or DMFT for those patients. So it's a, how are we doing the costing on these longitudinal data? We basically have a stream of DPT codes, of procedure codes, and each one of those we're basically multiplying by a cost. And the source of our cost data is from Truven Health, which is a database of reimbursement data. And we're basically, you know, using the mean amount of reimbursement for the state of Oregon for those dental procedures. And so if you, in that way, we can add up every patient's expenditures, if you will, or cost profile. And because we have the DPT codes, we can also categorize it as to whether it's caries prevention related, caries treatment related, or some other kind of dental services, you know, maybe periodontal or orthodontics or something like that. And then we can look at the spending over time. And our sort of hypothesis, and frankly, what we're seeing in the data is that, you know, there tends to be a lot of spending on the prevention and initial treatment up front, but it does, the cost, the amount of expenditure does go down over time. And if you look in the Willamette group, you know, you also see some associations with adherence to care, and other factors. So essentially, we'll be able to look at what the difference in cost is between the Willamette patients who are getting this prevention plan and other patients. And we'll also be able to measure the increment of new caries to if there's a difference over time, or the rate of new caries accumulation in those patients. And that's the root of a cost effectiveness analysis. And the other measure, which I put on here just for discussion purposes, which we're actually not using in the Medicaid analysis I'm talking about, but it's something that we are surveying patients at Willamette to understand, is this oral health related quality of life instrument, which again, as I mentioned, it's a survey that the parents or the older children would take. And on this instrument, basically, the lower score you get, the better your oral health related quality of life. And the higher the score, the more kind of oral health related quality of life issues you have. And that instrument's been validated, and it's designed for pediatric populations. It's been validated in a number of studies. We've used it in the Willamette population and seen, strong expected correlations where the patients that were assessed to have a high caries risk assessment, a high risk of future caries, did have higher scores on the POCWIL, which means worse quality of life. And the low risk patients had better oral related quality of life. We also saw, looking longitudinally, that in those patients who had an improvement in their risk over time, had better scores on the quality of life instrument than those who had worsening risk or that had no change in their risk. So all of that is encouraging in terms of, the idea that there is something this POCWIL is measuring. However, it's difficult to use in an economic evaluation because this scoring system isn't connected to anything that we can easily put a monetary value on. So it's hard to know how much is it worth paying to go from a high POCWIL, that means a bad dental health state, to a low POCWIL or better health state. How much is that worth? How much should we pay for that? And this POCWIL score can't be easily converted or translated to some of the summary measures of health that Lisa mentioned at the beginning, like the quality adjusted life year or a disability adjusted life year. It's not a utility-based measure. It's not grounded in some absolute notion of death or perfect health, the way a quality adjusted life year is, or a DALY is to some extent. And at the same time, we can't really use DALYs directly or other measures that hope to get at a quality in dental health, not because QALYs or DALYs could be useful in some dental health economic evaluations for adults with a certain level of severity to the dental health conditions. But when you have very small changes in dental health, such as, just a small difference in caries in children, these instruments typically aren't the instruments of using a QALY as a measure or a DALY, a quality adjusted life year or a disability adjusted life year. Those measures they're not high enough resolution to detect or measure, fine, small changes in dental health. And so, we felt like we couldn't use that as an outcome measure in this study. And while we can use the POCWIL, and we will use the POCWIL to sort of complement the story about improving oral health related quality of life, we can't really use the POCWIL to say something about monetary value or cost benefit, which leaves us in a bit of a quandary. And I'll just walk through how we thought this through. Basically we have to first figure out, does the program actually reduce decay overall? Are there fewer caries in those that are getting this program? If that's not true, then the program's definitely bad value, unless it actually saves money as well. But if you're spending money on a program that doesn't improve health outcomes, that's bad value. So that's very straightforward. But if the thing does improve, it does reduce decay overall, the next question is, does it save money? Are the delivery costs of the program negative? And in this case, that's a real possibility, because if you noticed in the trajectories that I showed, the dental practice focuses its resource on the high-risk patients, and they actually spend probably a little bit less on the low-risk patients than they would in a model that's undifferentiated by risk. And so perhaps, we don't know the answer yet, but perhaps they actually have a program that pays for itself, in that they save enough money in the low-risk patients, which is the vast majority of patients, where they save a little bit on each one, that they can reinvest in managing their high-risk patients, and maybe they come out ahead. So if we find out that is the case, again, we don't really have to worry about cost benefit or cost effectiveness that much, because we have a program that's cost saving, and as long as it's not harming health, then it's going to be good value. Now, let's say the cost, it doesn't pay for itself in the short term. So the dental practice doesn't see a cost savings from doing this. They're actually spending money on it. Well, perhaps it's just an issue of time horizon, and maybe over a long enough time horizon, there would be some returns. There would be enough benefits that the program paid for itself. Now, this is a tricky one, because this is, Lisa went through it very quickly, but an important part of these analyses is what perspective you're taking in the analysis. And if you're taking the organization's perspective, you really might be looking for returns that happen in a relatively short term, because there's quite a lot of churn of patients. They don't stay in your practice for forever. And so, especially Medicaid patients. And so you might, there might be something that's cost saving for society as a whole over the long term, but it might not necessarily accrue to the provider who implemented the prevention program to start with, for example. So that's the issue here, is about the duration of time that you're looking, and from what perspective. And then if it turns out that it doesn't save money in the short term and it doesn't save money in the long term, that basically means you have a program that has some health benefit, it reduces caries, but it costs money. And now we're in this last box at the bottom. Is what it costs worth it? Is the health benefit worth the cost? And that's the challenge we have to answer in this study, most likely. And we could use cost effectiveness as from Lisa's toolbox, which would be that we could calculate something like an ICER, an incremental cost effectiveness ratio, which would be something, it would sound like $20 per cavity prevented, or $5,000 per cavity prevented. And we could also do something called a cost benefit analysis, in which case everything would be expressed in monetary terms. So we'd have to figure out a way to value each cavity prevented in monetary terms. And I think at the end, Lisa's going to talk a little bit about how we plan to try to do that. But if that's the approach you're taking, then you want the net monetary benefits to be positive. That means good value. And meaning the monetary value of the benefits outweigh the monetary costs. The trick with the ICER, or the cost effectiveness in this case, is that when we say $20 per cavity prevented, I want to be clear that we've already accounted for the cost of treating that cavity had it occurred. So it's not a matter of comparing the $20 to the cost of doing the filling. It's after you've accounted for the costs of treatment, you still have a net cost of $20. And so you have to figure out, is it worth $20 after accounting for the cost of treatment to not have had that cavity to occur? So really, what is that pure health benefit, whatever that is to a person to not have a filling in their mouth, is it worth $20? Is it worth $50? Is it worth $100? Is it worth $1,000? And it's hard to say, right? If we were doing something like a quality adjusted life year, and we said, oh, this intervention costs $80,000 per quality adjusted life year, or $20,000 per quality adjusted life year, we have some benchmarks to know that what's good value or what isn't good value in the United States, what's worth paying for a quality. We don't really have a great sense of what it's worth to pay for a cavity, and we don't really know how to translate a cavity into a 0.000 something qualities. So that's the challenge we face in this project. And I'm going to turn it back to Lisa. I think she's going to talk for a few minutes about how we might try and figure out that monetary value of a caries prevented.
Does anybody have any? Sorry.
Yeah, should I pause for questions?
We must be really boring because nobody's asking us any questions. Either that or we're just like crystal clear, much better than we ever do. No questions, really, truly?
So you'll have to reshare your screen, Lisa, if you want to.
Yeah, I'm getting there. Oh, dear. I gotta get to the right page, which so what I'm going to talk about now is some work that has actually been going on for quite a while, but we're just starting to get out in the field. We had a little bit of a pause because of COVID. Originally, a lot of what I'm about to talk about, we're going to do in person, and we decided to move online, but that took a lot of thinking about how to do something that would normally be done in person over Zoom. So the question we're trying to answer is the one that Steve posed in that last slide, or the second to last slide, I guess. It's what's the value of improved dental health? The idea is to apply the benefit cost framework, where, as I said earlier, the value is based on individual willingness to pay. Willingness to pay in this context is a very precise definition. It's the most amount of money or wealth, more accurately, that an individual will exchange for a benefit that he or she is expected to receive. It's really important to realize that this is the amount that you would be willing to pay out of your own money for a benefit that accrues to you, which is very different than some of the ways that we typically think about these things. Actually, is a chat question. Oh, Steve, there is a chat question that more relates to you. Do you want to take that before I keep going?
Sure. Yeah, the question is whether people have tried to develop qualities for missing teeth or pain from caries, things that occur when caries are not treated. Yeah, there has been work that's tried to apply qualities and dollies to dental health conditions. And when they are more serious conditions, you can have some success, I think, because the impact on health is big enough that you can detect something with these kinds of measures. Certainly, missing teeth and pain, are things that are measured in it, like not missing teeth so much, but pain for sure is measured in the EQ5D, which is a general instrument used to measure health status that can be translated into qualities. And people have done specific work, in the space of looking at dental conditions like that. In our case, because we're looking at peds, and because treatment of the caries is an option, the long term, we would need, in order to look at a very long term, when these things start to happen where you might have root canals or crowns and things like that down the road. And I see Sung-In Choi, I think, is on the call, and we've had some conversations about, that life cycle model, or how predictive is caries as a kid to long-term adult outcomes when they start to get to be serious. And if you had a good model of that, which as far as I know doesn't exist, a robust one doesn't exist, but if we had a model like that, then you could maybe say something about, some of the major quality of life impacts of dental health that might happen in adulthood that you're foregoing, that you're dealing with if you prevent caries in children.
They may have more questions on that, or should I go back to where we were? Actually, if there's a whole interesting conversation here about the value of QALYs and how that relates to the value of these sorts of dental interventions. That's probably a topic for a whole nother conversation. But going back to the willingness to pay topic, the idea here is that we are each the best judge of our own preferences. So in benefit cost analysis, we are intentionally, in most cases, there are some exceptions, but we're not paternalistic. Economists like to talk about this as consumer sovereignty. It's the person who's making the purchase who's in charge, or the person who's going to benefit from the intervention. Where we're dealing with kids, because kids don't usually have control over financial resources and often have trouble interpreting the sorts of questions that we might need to ask in order to estimate these values, we usually rely on parents or sometimes other adults to act as proxies for the kids. The idea here is that the parent is the best substitute for the child's own preference, and we could have a very long conversation about whether that's really true, but that's the maintained assumption. Again, because this is willingness to pay out of your own income for your own benefits, it's really important to supplement this sort of analysis with distributional analysis, because a poor person's going to have less money to spend, so their willingness to pay for most outcomes is going to be smaller. But that doesn't mean that we don't want to have a program where we're benefiting poor people. So very important point. I don't understand why my keyboard's not working, but anyways, we expect individual willingness to pay to exceed the cost that you'd have to pay for treatment. Because individual willingness to pay should include any money impacts. These might include your out-of-pocket medical expenses, but they'll also include things like the travel time, the fact that you might have to miss work, so you might lose earnings, all of those things that have money values. It also includes non-pecuniary effects. Economists like to talk about this as just avoided pain and suffering, but basically that's trying to capture this whole host of things that we care about that don't necessarily have to do with dollars. In the health sphere, though, the presence of insurance really complicates the assessment, because the individual doesn't incur the full cost. So our willingness to pay for something that, for example, reduces our pain should exceed our out-of-pocket costs, or we expect it to exceed our out-of-pocket costs. It's not clear whether it would exceed the total cost, including the cost paid by our insurance company. You can imagine situations, we all know of many situations where something that's very expensive we wouldn't undertake if we had to pay for it ourselves, but we will unquestionably do it if it's insured. The other complication is that we do want to account for any changes in insured costs in our analysis. So what we usually do in a benefit cost analysis is we estimate individual willingness to pay, we sum that over the affected population, and then we add in any averted third-party costs. The best examples are insured medical expenses or dental expenses, but also caretaker time, particularly with kids. The fact that a parent's going to have to take care of the kid definitely matters. So we're doing a stated preference survey to try and estimate people's willingness to pay for improved health. These are often referred to as contingent valuation surveys because the value is contingent on a scenario that we're presenting in the survey. There's lots of good things about these surveys. We can tailor them to address exactly the outcomes that we care about. In this case, the outcomes from the preventative program that Wilmet's implementing. And we can implement it in a specific setting, in this case, Wilmet patients. A lot of people think, oh, I'll just throw out a few questions and I'll be all set, but that's not actually the case. These are very hard studies to do. They usually take many years, cost a lot of money, because since the payment's hypothetical, there's a real incentive to either just throw out some random willingness to pay number, or to think strategically. If I report a high willingness to pay, then maybe the government will pay for this. I don't want to pay for it out of my own pocket, that sort of thing. The other thing is that people may not believe what it is that you're presenting in the survey, and that's a real challenge. So in order to do a good job on these sorts of surveys, we do an enormous amount of pre-testing, which is what we're doing now as part of the project Steve was talking about. We include educational components in the survey, both to try and educate people and to test their understanding. And we include validity tests both in the survey itself, but also in our statistical analysis. There are a huge number of these studies that have been conducted in environmental economics. So the best practice guidance that's most current was developed in an environmental economics setting. So we do have to do a little bit to adapt it to health outcomes, and particularly to oral health. But I put the reference there because one thing that I've noticed in working in public health is that the economists, the environmental economists and the health economists often don't talk to each other very much. And this is a place where I think there's a lot of ways that there could be some mutual benefits to reading each other's work and talking to each other. So what's our goal? So we're not trying to value the Wilmet program per se, partially because that would be really complicated, but we wanted to also come up with a value that would be useful in benefit cost analysis of the Wilmet program, but that also might be transferred to other settings and useful to other researchers. So what we're doing is we're looking at the value of dental health improvements that are similar to what we think will come out of the Wilmet program, focusing on tooth decay, both that causes temporary pain and discomfort and requires restorative procedures, but also might have some downstream benefits. We have just started doing some online focus groups. We had our first practice session, losing track of time, last week, I think, maybe the week before. Once we fully implement them, we'll be talking to, we think, 8 groups of 5 to 7 Oregon residents. That number is picked based on how many people fit on a Zoom screen. There have been all kinds of things we've had to do to adjust to the Zoom environment. And in these focus groups, we don't go through the whole survey soup to nuts. What we do is we focus on the things that we think are going to be problems for us. One is the description of the dental health problems, making sure that people understand what those are. The description of the intervention and how effective it is in reducing cavities. The need to pay out of pocket because many of these people have dental health insurance. They may have a hard time believing that they're actually going to have to pay for this, or they may have a hard time believing that it's something good and they'd have to pay for it. And then the valuation amounts, because we need to make sure that what we present in the willingness to pay questions is within the range of where people's actual values are. We'll then do a pilot survey, which is basically the full, giving the full questionnaire to a small sample. My guess is at this point we're talking about winter and spring 2021, and then the full survey in spring or summer, which will be the much larger sample of there's a typo there. That should say the full WG sample, not to a small WG sample. Sorry about that. So the format of the questionnaire, once we get to the full survey, is We start off by saying what the purpose is. We collect background information on what do they know about these issues, what experience have they had, what are their attitudes towards dental health. We provide dental background information, educational information to engage the respondents and help them understand the context. We then define the scenario. We need to be very clear about what would happen to them without the intervention, what the intervention itself is, and what the likely improvement is. We elicit willingness to pay, and then we ask some questions to try and understand the rationale for the response to the willingness to pay question. That's both educational in and of itself, but also helps us weed out people who are answering the question in ways that just show that they don't accept or believe in the questions that we're asking them. For example, if they say, I wouldn't be willing to pay anything, and we say why, they would say because the government should pay. And we would treat that as a protest response because they're not accepting the scenario in the survey, which is that they would have to pay themselves. Then, of course, we have to collect demographic information on things like their age, gender, and income, in part because it helps us with the statistical modeling. I thought I'd spend the last couple minutes here just showing you one example of what came up in our practice focus groups, which has to do with the complexity of the scenario. We'll run into millions of other things like this, but since it's at the top of my mind right now, I thought I'd show it as an example. So our original scenario that we talked to people about in this pretest, I've edited it a little bit here to try and clean up some things that they found confusing, but we were struggling to try and figure out something that was fairly simple that people would believe you could apply to a kid, but that would help them into adulthood. And of course, because people lose their baby teeth, this was really challenging. So we came up with this idea of a coating that's on your kid's gums. So it's sort of same idea as a sealant, but on the gums, so that it would, the idea would be that it would have some lasting effect as the teeth are growing, the adult teeth are growing in, and no other effects, no side effects, no change in what you have to do after the treatment. And we talked about what sort of reduction, what we led people through, start off with what the expectation was of how many cavities they have without the intervention. Then we ask a willingness to pay question. In these surveys, we almost always express willingness to pay as a take it or leave it amount, $100 in this particular case. And then we vary the amount across respondents because it mimics what we experience in the real world. You walk into the grocery store and there's prices posted. When we have it more, researchers have found that when we ask more open-ended questions, that people have problems responding. People have real problems with this gum coating. They just didn't believe it. They want to know all kinds of things that we would have to make up, and it just got very complicated. So I'm now thinking that in these focus groups, we also need to test a second, simpler scenario that we've seen researchers use in other settings, where it's completely unspecified. Suppose there is a one-time treatment that leads to a lifetime improvement in dental health. So that's where we are now. We're trying to deal with how to present this in a way that will give us useful and valid results. That's the end of the slides. I'm happy to answer more questions. I'm also happy to talk to people outside of this presentation. Both of our email addresses are there. But let me stop this share and see if anybody has more questions before we need to break up. Christina, I think this is a question for you about the recording, whether it will be available.
Yes, it will be available probably sometime next week.
Okay. What else?
One thing I would, is to say is that I think, we're certainly available to discuss if there's, if you folks have research interests related to economic evaluation and you want to talk about them, you know where to reach us, I think, and we're happy to talk.
So what do you think? Should we let everybody go? Oh, thank you, Joe. Should we let everybody go on with their day? Or are there a few last questions? Oh, sorry, Jane's asking what the policy implications might be. What do you think the potential impact of this work could be? I think you should try and answer that, Steve.
Yeah, there's a few. So, certainly, there's a set of policy issues just related to capitation and incentives and so forth, which may evolve out of this because we, in looking at the other one, potentially is if you did find, I guess what I'm saying is that if you did find that, if there was some cost or investment in a prevention model like this, but it did lead to some longer run health benefits in terms of oral health, that would be useful, but it doesn't immediately solve the problem of how to make it happen, because in the payment model that Willamette has, in a capitated model, assuming the churn isn't so high that they can get some of the benefits, then it makes sense for them to do this. If it costs money, then until it's it would lead you to think that you'd have to shift the incentives for investing, paying for risk assessments or paying for performance in terms of compliance with treatment plans or something like that. And the other thing that could come out of this from a policy standpoint, I think we might learn something about how much value. I'm being optimistic here and hoping that the willingness to pay study, the stated preference willingness to pay study that Lisa was describing, if it works, and they don't always work, they're difficult to do, and there are a lot of stumbling blocks in terms of making a stated preference study work, but it could help us understand how much people value preventing dental decay in their children, which could give you some idea, what's worth investing in it and so forth. And then the grant also has some aims that are related to disparities reduction. And so, if it turned out that this was working, you might see some idea that this might be an approach perhaps to reduce dental disparities within between a high or average socioeconomic status and a Medicaid population, potentially.
Yeah, someone asked for the contact information again, so it's I put it back up on the screen. I think you can find both of us if you just Google our names. Oops. Although I shouldn't be confused with the Rolling Stone critic. That's my my next career. Jane and Christina, did you want to say anything more, or what's next?
Thank you for a fantastic talk. I enjoyed it very much. It was very informative. You covered an enormous amount of material in a very short time and did so very clearly, I think. So we really appreciate it. We look forward to staying in touch, learning more, and I suspect that you will be hearing from some of our students and faculty. So thank you again.
All right.
Thank you for having us. I just hope that the next time we talk to you all, it can be in person so we can actually see your faces.
Us too, us too. Bye, everyone. Thank you.